Hi, I'm Vicky Gilman, the Curious Case Manager, and in this series for NR Times, I shall be today interviewing psychologist Dr. Melanie Lee. And Melanie is going to talk to us about a number of things, particularly related to the field of pain management, and she'll cover within that things like EMDR, ACT, CAT, lots of acronyms. I'm going to let Melanie tell you what they mean. She's also going to talk a little about compassion and bravery within the treating rehabilitation teams and share with us some of her lockdown insights and experiences recently of remote working. So I hope you enjoy this as much as we have, and without more ado, here's Dr. Melanie Lee.
My name is Dr. Melanie Lee. I'm a clinical psychologist and I'm also trained in cognitive analytic therapy, so I'm a CAT practitioner and more recently an EMDR therapist as well, eye movement desensitization reprocessing. And I currently am the director of Trust Psychology, which is a service in the northeast of England that offers psychological services to a wide range of clients across our region, with a number of associates working alongside us, and our new division, which is very exciting, of Trust Pain Management, which is bringing together a multidisciplinary team to be able to offer something quite different to clients experiencing chronic pain from the perspective of psychology, but also occupational therapy, physiotherapy at the moment too. So that's me.
Well, welcome, Melanie, and thank you very much for joining us. Got a few questions to guide our conversation today, to find out just a little bit more about what you do, what motivates you with that, the challenges you currently face, and the developments and what excites you in the world of pain management, if we can focus on that. So can I ask you, first of all, what motivated you into your current role?
Ever since qualifying in 2008, it's just been about collecting where my real heart and soul lies in terms of the client groups that I work with. So finding the best match between the therapy approaches and the client need. I've always been fascinated by the mix of the art and science of psychological approaches. So you're doing this dance with your clients that needs a lot of intuition, but at the same time based on scientific knowledge and theory. And I always found that the health interaction, the mind and the body, drew me more than other approaches. So found myself working with adults in the main, but particularly with health conditions or other forms of injury, which has now led me to be focusing my main clinical expertise anyway on that population. And having had the relevant NHS experience and working across a different range of settings within health, set up Trust Psychology to be able to offer a service that I wanted to offer and be less restricted by potentially some of the inevitable limitations and resources that were part of my previous roles. And that's been brilliant to be able to offer what I felt my training trained me to do.
Can I ask you a little bit about pain management in particular? What drew you especially into the management of pain?
Yes. So when I was working in the health psychology departments in my first role as a clinical psychologist in the NHS, I had access to all of the different health specialties across the hospital. And what I got really drawn to was complexity. So finding ways with clients where there'd been a traditional medical, biomedical model approach towards the dominant model really in helping somebody, and that would get us so far as sort of in humanity terms, but there was still so much more opportunity to add something to somebody's experience to alleviate their suffering. I just felt psychology was very underutilized in those areas. And then a pain specific job came up and I went for it, and I just loved that combination of being able to work as a team together, because it absolutely, because of the complexities, needs multiple heads from multiple professions to make sense of what's going on for somebody, but felt really valuable as a psychologist within that role, which was interesting because I found outside of the role, people were asking me, what on earth can a psychologist offer to pain? Because it's so dominant in society that we think of it as a medical problem and about being injury and recovery of an acute damage to tissue. But as soon as you start opening up all the theories about the mind and body, and you start to see the results when you apply that theory, it was an area that I thought had so much potential for development. And I'm still finding that today, that I'm getting experience of clients or outcomes that I wouldn't have thought possible even sort of 5 or 10 years ago.
Can I dig a bit further with what aspect of your work you're currently most excited about then, around pain?
Yeah, because the area is developing so rapidly, there, particularly from a psychological perspective, it's a really exciting time to be involved in pain management, and particularly the overlay with trauma, because it's very difficult to think of an experience where you'd be left in pain that you haven't had an event that has been traumatic to you to some degree. And then of course we're thinking about layers of trauma there, whether or not the event itself was traumatic, because of course the definition of trauma is a life event that causes actual or potential harm. And then we know now, with all of the neuroscience and developing research, particularly into the more relational aspects of how the mind and the body connect and what the impact of early life experiences has on our entire nervous system, that the way that pain is experienced can get held in that nervous system. So the levels of trauma that we might have historically thought about only related to certain populations or with the diagnosis of PTSD, all of a sudden opens up. And there is lots of neuroscience evidence now that points towards quite specific applications of therapy, because now we know more about the theory and why someone might still be experiencing pain after potentially a period of time has passed, or their injury might have be on the process of healing biologically, yet the system is still activated. And now that we know why that's happening, there's a few different areas that are coming together. This idea of the nervous system and polyvagal theory is becoming very popular in psychology, that then influences all of the EMDR treatment and how memory is impacted in trauma as well, because traumatic memories are stored differently. So if you amazingly target some of these things, people report less pain. And I just find that fascinating.
You up on EMDR there and ask you just very briefly, could you explain what EMDR stands for and the theory behind that?
Yes, so it's an approach that's actually been around since the late 80s, early 90s in America, but in the last 10 years in particular, it's really taken over as being something that offers really quite transformational change to people's symptomology, starting off with a particularly targeted for post-traumatic stress, but now in a range of areas. So it stands for eye movement, desensitization, reprocessing, which means that we're doing something in a moment with a client where we are literally at one point in the protocol asking them to move their eyes from side to side, literally corner to corner, as fast as they can, whilst holding a traumatic memory in mind, because memories are stored with a number of different component parts to them. There's the picture, the image, there's the emotion attached to it, there's the physicality of it. Your heart will still be racing. There are beliefs attached to it, like I thought I was going to die. So yes, this concept of activating the right and left hemisphere of the brain in fast alternating patterns, right, left, right, left, right, left, does something neurologically that we're still really exploring exactly what's happening. There's a number of different theories, but the effect of this, when it's done by a skilled, trained therapist in the right context and the right conditions, enables someone to bring to mind a traumatic experience and not have the residual symptoms that they've held on to often for years. So you can experience the memory, but it's now effectively classed as a chronological memory and not a trauma memory, meaning you don't have the fear attached to it anymore. You then are enabled to engage in behaviors that previously you wouldn't have been able to engage with. And people report a real sense of calmness, but also the fact that that experience of their lives gets integrated into the narrative of their whole life history. It's something that happened to me, but it doesn't define me anymore in terms of what I'm now able to do. So the past is not relived in the way that trauma is so horrific. And amazingly, if there are physical elements that were causing pain at the time of the injury, they can be relieved in terms of easing of pain symptoms, to the point where someone can be feeling something, experience the eye movements, and then the pain just goes away in that moment as part of the memory. And it's very exciting to see this happen with client after client, but also because you receive the therapy yourself as part of the training, there's a real visceral sense of, I know what it feels like for that to shift. And then when you see that same shift happening, you can see clients' faces and bodies transform as they go through. So at its core, it's miraculous, but of course, nothing's too good to be true. So it needs to be done incredibly carefully, because if we are unable to access the memory because it causes too much distress, or we cut off and dissociate, it can be quite a dangerous experience to go through. So it needs to be thought about and done incredibly carefully, but in the right conditions, it's one of the most transformative therapies I've ever witnessed, really. And I think the opportunities for pain are so exciting, and I'm really starting to get deeper into that with a number of clients. The challenge being, of course, is getting onto the same wavelength about what you're trying to achieve. And because all of us have these ideas about pain being a biological medical experience, and opening up the idea to pain being multifaceted and actually top-down therapy offering some symptom relief is quite a concept for people to get their head around. They need to experience it to really believe it often.
That is exciting and fascinating, and such a positive development. But I'd like to, if I may, just ask you something about the flip side, really, and in terms of over recent years, what might have been the greatest persistent barrier to you in achieving positive change for the people that you serve?
Yes, there are barriers, aren't there? And one of the things that drew me to working in a team is the opportunity to have a diverse range of experiences, but also opinions, because I think one of the barriers to all good rehabilitation is sometimes we're bringing, as therapists and clients, our own prior assumptions to a situation that mean, often through necessary need to protect yourself, protect your identity and your profession, that you'll do things as you've always done them. And so patterns, you'll be quite habitual and in set ways of doing things. So one of the greatest challenges is working together as a team to help somebody shift what might have been habitual and kept them safe up till now, but actually is not serving them at all in the management of their pain. So taking the example of someone who maybe copes with emotional distress by being very busy, or working hard, or throwing themselves into work, then all of a sudden they experience an injury, but they cannot engage in that same coping strategy. They're an absolute loss then as to how to move forward in life that still maintains who they are as a productive person, but in a situation when their body's not allowing them to do the same level of energy or activity. And as well as working with clients on identifying those repeating patterns, which is where my CAT training really is hugely valuable, because you can pick up people's patterns incredibly quickly when you work with them. the way we move, the way we describe the nature of our problems, all gives us a hint of what somebody's been through in their life up till there. And what I'm finding with teams is if teams are aware of those processes, then we can help in ways that are sometimes counterintuitive, because often as a team, we want to be very responsive, very reactive when a client has a difficulty. But if we are unaware that actually that can be part of a client's repeating pattern throughout their life, that they throw themselves into things or they're looking for us to rescue them, then actually we're hindering their ability to make independent progress and be able to receive the feedback of empowerment that they need to through discovering that themselves. So sometimes the role of a therapist is containment and management of that trust and safety to allow the person to come to their own solutions rather than us jumping in with idea after idea or technique after technique, which we're trained to do. We love giving ideas, we love giving advice as rehabilitation therapists, but actually, unless the team has an understanding why that individual is behaving in that way, we unfortunately can be counterproductive. And I've seen it time and time again when we as a team are caught in the unhelpful pattern and none of us are aware of it until we've got the theories.
So Mel, are you saying there that the very techniques you might be using with your patients and your clients are also techniques that you might use within the team to take away those barriers?
You can absolutely use those theories and principles, yes. I think the key word for a psychologist is all about formulation. When we hit a block or a barrier in someone's rehabilitation progress, because no journey is ever smooth, then we need to ask ourselves why that person's behaving in that way without assuming that we know. We're quite quick sometimes to jump in with they maybe don't know this piece of information, or they maybe just haven't practiced this technique enough, rather than stepping back and saying, but we've seen them do this, not just with this technique, but actually with answering phone calls or in conversation with us in other places. There's a pattern here that probably predates their accident. So being able to have a way that the team can have a common language to talk about that and understand that. And I think that actually takes a highly reflective practitioner. You have to be prepared to question your own style of working with someone, be incredibly honest as well about naming the moments where you're frustrated as a practitioner with a particular interaction, and say there's something going on here between us that can be understood, because it's highly likely if I'm feeling frustrated that my other colleagues will be too, and absolutely the client will be. So having the trust to name those experiences, even if they sound like they're going outside of our professional boundaries about being something we'll be willing to admit, they're the real moments of change I've found in teams, where we come and we name tensions and we name things in order then to understand what's going on within the whole system. But absolutely the techniques then, if we are aware of what works and what doesn't, we can apply them to ourselves too. And I'd really commend any therapist to be putting into practice what they're teaching, because often we don't. And only when we try that, we recognize it's much harder than it sounds to change your habits and do things anew if you've been doing things a certain way for years and years.
It's an interesting reflection, and I think it probably speaks to the next question I was going to ask you, which was about drawing from your experience, what could we learn that would help us achieve better outcomes for people we work with, which I think you've probably outlined quite well there. So I'm just going to go back to barriers and ask you one more question around that, if I may.
Yeah, sure.
It's just pulling back a little bit to the sort of even bigger picture of, you mentioned working in the NHS and also working in the private sector, whether there are any barriers at a larger scale that you've encountered?
Often, I suppose it's about culture and ethos, isn't it, when it gets to larger barriers. So it is a really lovely experience when you meet a colleague or another, if you're working alongside other teams and services, when someone has the not just psychological mindedness, but the openness to be exploring a potentially different way of looking at a problem. And rather than assuming that pain has to be dealt with through medication as the first line of the first sort of option, for example, just because that's historically what's done. And then it's that part of the system where we don't know what we don't know, and being open then when new innovative ideas are coming in to really trying to understand what the principles behind them are. But I suppose in the greater scheme of this, the more of these systemic barriers that you're asking about, one thing that I think is across the board often, particularly in therapeutic approaches or protocol-driven techniques, is that we are so keen about doing things systematically and evidence-based that we have a set of steps that we follow that absolutely are needed and need to be thought about very carefully. But I would encourage people to really understand the principles behind those therapies rather than feeling they have to do it in a set order at a set time, because human beings are complex and they do not fit into boxes. So a formulation-driven approach is what really inspired me to do more with trust psychology and trust pain management, to be able to think for this particular person, this is why they're experiencing the barriers that they are. And rather than receive a report that recommends a certain number of sessions or a certain protocol-driven approach, because that's what the evidence base links in to suggest, have we got the flexibility to take those guidance and then adapt it almost session by session to what someone's communicating, because all resistance to me is a communication of some other need that we're not meeting, and we can easily miss individual clients' need through just applying a standard technique or system without really delving deeper about someone's expectations. So I was talking to our team recently about a kind of upside down triangle, whereby the top two corners represent therapy process, or do I feel safe with this practitioner, the trust and safety. Formulation, which is, are we working on the same problem? Do we have a joint collaborative understanding of what we're trying to do? And then technique, structure at the bottom of the triangle. And my experience has taught me that if you don't address the top two, if you don't have trust in the relationship therapeutically and with the team and a joint understanding, you can forget about the technique, because you're just going to get stuck and stuck and stuck. And then having the practitioners trained and skilled enough to be able to know what to do to keep the trust and the safety there, because it's more than just speaking to we can throw out these concepts of we've got a good relationship with our clients, but I'd really ask people to say, what does that mean? What do you do together? What are you able to, what level of attunement have you got with where their stuckness is? And the negotiation of the goals and the problem solving where we want to get to needs to be a real negotiation, because as practitioners we can know exactly where we want to go, and we see the client as stopping us reaching that potential, and the client will be thinking the same. So it's going closer towards problems and being really open to working on those two principles before you go near the technique. And I think, especially when you've got huge organizations, it's easy to teach technique, it's easy to teach protocol. It's much, much harder to have someone reflect on what they're bringing therapeutically to the safety aspect. And of course, when you're talking trauma, if someone has adverse life experiences, which we all have to a certain degree, their trauma and safety will be expressed in the nervous system. They will be unable to do certain things until you help them move past that point. So it's the flexibility, I think, of an application of techniques that
and I think there are some themes around not working individually, working as a team, something very much about reflective practice, something about protocols not necessarily driving things, it being more an individual formulation. And I guess a sort of trust and safety within the therapeutic relationship, but also within the team to be able to have those discussions. So
Absolutely. I've experienced some real transformative moments in teams when actually quite a difficult issue, what has been experienced within the team, is, you know, bravely brought to the fore for discussion. And it's about that honesty of knowing yourself and knowing that this is how I usually practice, but this client's almost pulling me out of shape. I'm doing things that I wouldn't be normally doing, and being open enough to go to your colleagues and saying, is that happening for you too? Because of course we cannot know on day one how that's going to play out. A relationship is a toing and froing and a development. You see how your client reacts to various things. You cannot know all of that at the beginning. So my colleagues in the team, all of us contribute such valuable information to seeing how clients present in different contexts and different points in time, and then us pulling all of those pieces together to just keep refining our understanding of what they're going through. And as soon as you attend to that trust and safety and the client feels that you're with them, the progress just starts opening up. Like those barriers melt away more, and the technique is easy to put into place. I would say the technique's the easy bit, actually. The really challenging bit is working on the safety and the collaborative formulation.
You used the word bravery there, which I think that's quite an interesting term, the bravery of that it takes from the professionals to working and describing. And I think bravery isn't necessarily a term that we hear that often or that we think about. I don't really want to say anything more about that bravery.
Yes, I'm glad you picked up on that, because one thing that I often do when I teach about pain management is ask practitioners, how willing are you to go towards your own pain? Because pain as a natural human experience is something we want to move away from, protect against, because it's an unpleasant experience. At its worst, it's agonizingly horrific. So it goes against everything that's fun and enjoyable about being a human being, but it's part of life. And I think the hardest bit of our work is to be willing as a practitioner to know your own pain well enough to be able to be with somebody else's pain. Because too many of us are too quick, through absolutely just not knowing about this experience, to try and make it better too quickly. But from a point of view when something is deeply damaged, both mind and body, it can't be better really quickly, but you absolutely have possibility to alleviate suffering with time and patience and with a compassion. I think compassion is absolutely crucial alongside bravery, being willing to sit with someone who's in agony and just almost modeling the facial expressions that they're experiencing in that moment too. So when someone is describing their pain, we quite often write it down or nod or acknowledge it. We think we've validated it, we think we've acknowledged it, but to the client often we haven't fully until we've attuned, and often that takes actually a moment of exchange between you. That could be eye contact or shifting your breathing or body posture. But it's the right brain, left brain stuff again. The client hears so much of what we say, but they feel what we were like in the room. And if you can sit with someone's pain, and that often needs to happen a lot at the start of the treatment to build that collaborative relationship, really understand how awful it is and where it's experienced in the body, that will give you a lot of indication about where you need to go next. But I think as practitioners, we automatically, without knowing about this, move on too quickly to the solution without really taking the time to understand the existential experience of it. And to do that, you have to know your own pain. You have to be willing to think, I'm going to feel awful after this session. Do I know how to look after myself to enable me to be with that person? But the person will more often than not report that it was a really beneficial session because they felt deeply connected with. There was an absolutely wonderful phrase. One of the benefits actually is I have been making myself a bit, but allowing myself to read more of the therapy books and some of these theories that I've been wanting to for years, and I've been buying the books, but I've been dipping into it, and you get so excited once you read a chapter and you're like, yes, this is what I've been looking for, that it encourages you to read a bit more. And there was a really lovely phrase that I came across the other day, which is about, the the problem that the client presents you with, the resistance, that's the work. Like that's not the problem to overcome. That's going to be the heart of everything you do. That's going to be so helpful for them, because the people show so much of themselves when they come across problems and how they approach them. So I do have this inherent optimism, which I think sometimes gets frustrating at times, because you know it's going to take a long time, or you need to be incredibly patient. But it's never a case of we can't help this client. It's always a case of what's the barrier. Sometimes the barrier will be inherently too much for something to shift, but it's always that, and what do we do? Like, you just go towards that and allow space. And actually, fundamentally, as we've just said, the first thing you do is you just sit with it to understand it fully. Now, it's hard on one level. It's not complicated though, is it? Like, all of us can do it. We can all sit and ignore it. If I don't understand what's going on with someone, I'm like, right, whoa, we have to slow down, go way back, because there's something not helpful happening here. And the person often really thanks you for naming it, because otherwise you just, we'll try that next time, or we'll try that next time, rather than going, why are you so stuck? Does this happen in other points of your life? And they go, oh yeah, it's happened since.
And I think in terms of that thinking about neuro-rehabilitation, it seems to me there are a lot of people within the therapy teams, and fixing has been the way that we have learned our craft.
Yeah.
Define the problem, find a problem list. It particularly comes from the more physical side, I think. Define your problem list, and then you're trying to knock off each of those problems by fixing each one. But the more experienced one becomes, the more you start to realise that it isn't that. Although it might be very important things, and there are things you can do to fix things, and equipment, and all sorts of solutions, and that's wonderful. But behind that is something much bigger, much more encompassing, and it's all the things that you're talking about. And so these are that's why I picked you first, because this is fundamental, I think, to every rehabilitationist. This is what we learn. You either learn it at the beginning if it's very much part of the central thing that you do, or over time you start to realise that you can't do what you do without starting to understand more of this.
Absolutely, yeah, absolutely. That there, I think there's principles that we can all relate to, and one of my challenges in a team, I suppose, is working out where the psychologist's job starts and ends, and where other people's roles take over, whether they're aware of some of the things that I'm talking about and I'm aware of what they're doing, but we also respect where each other's coming from, and that we will have different takes on it. And it's not for everyone to be doing all aspects of that all the time, but just to be aware of it, and then to know that maybe the psychologist will be going deeper into it perhaps. But it makes me think of a case study when you were talking there that I sometimes come back to when I'm doing some presentations on pain, about a client who seemed resistant on kind of working towards certain goals that would just not make, something would be set by the OT, then we'd come back the next week and it wouldn't, there'd be an excuse why it hadn't been done, and it just kept happening. And actually, in delving into that client's history, we're forgetting, if we're a series of practitioners that just go, meet that problem, tick, do that goal, tick, and work through that, we're not addressing something really core, which is, if you get better, you're all going to leave me, and I'm going to be living with this for the rest of my life. I'm just a year or a month of your life. This is my whole life. So I don't want you to leave me. So I will, without realizing, sabotage things slightly, or find ways that I need you more. And it's not that I'm not capable of doing this. I just emotionally feel deeply unsafe at the thought of you going. So as soon as you have those conversations about the ending, and what will it mean when what will you be, and shift that perspective from you're not leaving me to you're empowering me to live my life independently, and you're there if I need to check in, but I don't need you. I'm growing and maturing developmentally. And to have those conversations with adults is challenging, because you're touching on very childhood issues, really. And you don't want to patronize, but actually you're talking sometimes to emotional problems that are very little. But they're key things that like, actually, if we just come in with our agendas, we're forgetting that could be really quite counter to what the client's agenda is. And we need to fully understand, everybody kind of wants to get better, but actually getting better means letting go of certain things too. You might be asking them to change a fundamental coping strategy that's been their psychological defense their whole life. They ain't going to do that. So and I'm thinking about these ladies that experience back pain or fibromyalgia pain who have been carers all of their lives, and you're asking them to rest and take pacing breaks and look after their own needs. They've never done that in their life. That's not how they've kept themselves safe. So until you go there and have those conversations, you're going to get barrier after barrier, and everyone's going to feel like a failure, which is a repeating problem. So there's...
And everyone, including the therapy teams, I find, and that can be... So, you know, if you focus on the fixing and sorting, often those... Even if you have some success, they don't stay fixed, and then you end up with huge frustration about, I put all this effort in and you've achieved, and now we're back where we started, and that's very difficult for teams. So that sort of circles us right back round to the early points you were making about
one of the most exciting things about the trust pain management team that we're working on is coming up with systematic ways that we can capture these early patterns from assessment and early sessions, because it is a skill to capture it and know where it's going. But if you capture it and you can map it out from a CAT perspective, you can predict all of these things happening, which is really helpful. So there's some clients where we know we're going to hit a barrier when we get to that point. So, but that's because their history will tell us that that's likely to happen. So let's talk about it as soon as they feel ready to talk about it. And then at least when it happens, we're fully prepared for it. We don't beat ourselves up about it. But actually, because you've anticipated it, sometimes something might shift before then, and it's not as big a barrier as you expected. Yeah. I often come in with quite a pessimistic view of we're not going to get anywhere. And then, oh, look, we are getting somewhere, because you take all the pressure off rather than say, be too ambitious and too optimistic. And that's a systemic problem as well, isn't it? In reports, we're going to achieve this by this date. And actually, if you go on the side of, we'll do what we can, but we're going to fundly concentrate on the fundamentals, and then what we achieve is just a byproduct, because the structure and technique bit will come once you've got that process and formulation and therapy relationship working well. And sometimes I find that maybe in a team setting is quite surprising, my response to certain things when things don't get achieved or are problematic, and I just go, yep, we knew that was coming. And rather than being like overly reactive to it or responsive to it. But if you think about it from a teacher student or a parent child, there's so many elements of learning and development where you have to wait and just be there and be present. And we said, we knew this was going to be problematic for you. You have fallen. So what do you need to help yourself get back up again, rather than, oh my gosh, you've fallen, let's quickly do what we need to do to get you back up again. Then the child goes, well, I need you to help me when I fall. I can't work it out myself.
Yes, there isn't the learning for the person themselves as to how to manage that situation or why it improved.
Yeah. A supervisor said something absolutely, Vicky, that a supervisor said something wonderful to me on those lines a while ago, which is, if you jump in too quickly, you're taking away that person's pride in themselves at achieving it. Like the sense of pride and confidence and self-efficacy when you do something is so wonderful to the psyche, that if others constantly do it for you, you're actually taking away that person's opportunity to feel that.
Well,
and I think that was a wonderful thing to hold on to.
There are probably some interesting dynamics in there, I suspect, too much for this conversation, but in terms of the pride perhaps that team members take in fixing people. So yeah, there is perhaps the potential for a tussle between the pride the patient needs to feel in that, but the pride that the practitioner might want to feel about fixing that.
We have, I think sometimes some really skilled therapists are actually incredibly humble when someone says, oh, you've changed you've done something. Because actually, you've done it. I've just taken, and I like the idea from the MDR, I've just taken the barriers away for you to reach your own development. Actually, I didn't do it for you. But there are times when you do have to know yourself so well to bite down when someone says, oh yeah, I got better because I met my new boyfriend, or the case concluded, or that's what made me better. Yeah.
But to feel one has achieved for oneself is surely a more sustainable, likely to be a more sustainable position.
Absolutely.
Can I just touch upon current situation and ask you to tell us a little bit about what specific challenges you're facing right now? We're obviously in a situation of lockdown due to the pandemic. So very interested to know what challenges you're finding with that and what positive steps you're taking to overcome those challenges.
Yes, there are absolutely challenges, aren't there? The greatest being, I think, how can you offer this presence and therapeutic relationship through either a screen or a telephone call? So with the current lockdown that we're in, we are unable to be face to face with people in certain contexts, in certain care situations. Absolutely, people are having to work around the PPE and be able to offer that more direct care. Oh, Vicky, I can hear a slight echo of my voice on the. Oh, it's just gone slightly now. I don't know if I was.
We had a slight connection problem for a moment, but I think we're back in the room.
Yeah. So yes, maintaining this experience of connection and attunement and compassion when you are less physically connected with somebody is a huge challenge. Never mind the making sure that if you're not seeing people's emotional expressions, or you're only seeing people from head up or shoulders up as well, you're getting a disembodied head as part of that experience. And there's so much body to body communication that happens with people. And especially if you've got hands-on therapy, or you're doing things that really need you to show how that operates. I think there are real challenges in people feeling understood and connected with. But at the same time, the real benefits of this situation are you are to attend to that connection so much more. So I can certainly think of teams where we've had greater contact and frequency of communication than we had prior to lockdown, because we all know the importance and emphasis of this. And that opens up the thinking beyond this point, doesn't it? About actually, it's all about communication and maintaining relationships and checking in, and the benefits of just being thought about, especially when isolation and loneliness is such a big problem right now. There's people, if you're lucky enough to be surrounded by people that you love and are supportive, that's wonderful. But there's so many people that aren't, or unable to engage in the really helpful coping strategies that involve exercise, that involve social contact and communication with others. Those have been stripped away temporarily, but we don't know how long this is going on for. So the lack of control, the lack of certainty, the social isolation, all of those are stressful to our human psychology. And what seems to have been one of the greatest benefits that I've seen in both people that I've worked with or trying to offer it as best we can at the moment within a team is this just being as kind, as compassionate and flexible and understanding as you can be, and recognizing that we are all in threat mode right now. There is nobody that's immune to this, which is in such an unusual situation. And I'm actually having some clients reporting to me for the first time they can see their family or friend with levels of anxiety that they experience on a regular basis, or having real restriction to their mobility, which people with injuries have all the time, but other family members may not relate to as greatly, are now relating to. And that is that relation that some of my clients are finding that they're actually coping better with this scenario than they would have predicted they would have, whereas others are finding it much more challenging. So when we're in threat mode, we can't take on new information particularly effectively. We can't really plan ahead. We've got limited control. We all really there's so much uncertainty, that taking things one day at a time, the mindfulness approach, emphasizing just core Maslow's hierarchy again, absolutely core. Do you feel safe? Are you eating and drinking? Are you sleeping okay? Are you getting outside sunlight on a regular basis? These things come absolutely to the fore, and we can all learn from that in the longer process about not overlooking these absolutely core aspects. But time and time again, I think it's the compassion and the kindness that is the go-to in terms of what the first thing we need to do with everybody is. Take the pressure off, acknowledge the situation, and give people that opportunity to get to know themselves, but keep connecting, keep checking in, even if you don't feel you're doing anything that helpful. Actually, for the first time, you're seeing a bit more of, we can be quite protective as practitioners, can't we, of our own spaces, or not wanting to disclose too much, but it's so transparent right now, and people are accepting of it because actually everybody's in the same situation.
I think so, and I think starting to make people realise that those things, I mean, they're quite, having a little look at what's behind people on their interviews is quite interesting, isn't it, on the TV?
Yes. Yeah.
But that it doesn't matter as much as it perhaps felt like it did. It doesn't make you think any lesser of somebody or any more of them. You just observe it with interest, I think. But that's all. And
yeah.
It doesn't feel like an intrusion just to see what you and I can see of each other's houses, for example, at the moment.
That's right, and that, I suppose, that highlights another really important point, I think, about when we're talking about sitting with or being able to connect with your own pain when you're sitting with somebody else's pain, that we can, as practitioners, have a kind of professional veneer that we feel is an appropriate boundary. And absolutely, you need appropriate boundaries, and it's not okay to disclose certain things, and it's very unsafe in certain situations. However, to be human with someone, so if someone's very tearful and I feel it myself, it's absolutely fine for me to cry with them. It's absolutely fine to be able to connect on that human level, because that actually offers somebody something that they're going to not get elsewhere potentially, because you've really got to be with someone to feel that level of emotional connection. So I think this
sense of humanity and connection is even more important at the moment. So the fact, I know it's just a logistical thing that we're all forced to do these types of calls from our homes. Maybe there's something very important about that, in fact, at the moment, as luck would have it.
There is, and I'm noticing your hand as well, because actually it's making me think that there are moments where slowing down and just really attending and doing things that make a big difference, but maybe in other settings we might have dismissed. I have found have come into therapeutic encounters a lot more. So I have asked people to actually sit from an EMDR perspective with their hands across their chest and tap alongside me, because I'm more in tune with them in that moment, and allowing people to just, I've been doing breathing with people over the video link in a way that I might not have done to the same degree in a face-to-face meeting, but the benefits have been enormous. And just getting people to know their bodies and know that there's things that actually, hand on heart, actually is an incredibly soothing experience that activates aspects of our nervous system that can calm us down and stop the fight and flight response, that we just skim over because we're coming up with clever techniques as opposed to thinking about what does somebody need in this moment right now. And I find we're attending to that more given the current situation, because you feel certain techniques are less possible over a video screen. So actually we're slowing down and going right back to basics.
More concentrated in a way, so you can't see the rest of what I did, but that I didn't realize I did it, but you noticed it. So I appreciate we can't see as much, but maybe we're more in tune with the things that we can see. Do you think?
Yes, I think so, absolutely. And you've got permission in these moments to note that I think that concept of noticing is so important. If someone notices something that you do that you weren't even aware of yourself at times, it's hugely connecting and attuning with. And then you're inviting the client to notice when you do that, is your pain worse? Just notice when you do that, your pain's better, because it takes us away from these black and white. It always hurts. It never gets better. Actually, moment to moment, there's so much going on. Let's invite that awareness and let you learn without me giving you things to do. Actually, if you're in touch with your own body and mind, your wisdom is there. And EMDR's got this wonderful concept that at the core of our bodies, we will heal if the conditions are right. Actually, the practitioner doesn't need to do anything other than create the right conditions for the brain to heal. And they get blocked by beliefs. They get blocked. That healing process gets blocked by many things. So actually, you say very little when someone's processing, because you're allowing their brain, because it's happening at such a range of different levels that the talking, the cognitive front part of the brain interferes with it. We want it just to happen. So there's lots of opportunities now to be exploring these things. And it is, although life will return to something, we'll all look forward to that, there'll be elements of this that I will miss or think about how to maintain in my day-to-day practice more.
And what you just mentioned in terms of noticing something and perhaps just asking your patient to notice it and to note it, to sit with it, to acknowledge it, I guess.
Absolutely.
Does that relate back to ACT that you were talking about earlier?
Yes. So psychologists are full of acronyms, aren't we? So there's CAT, which is cognitive analytic therapy, which at its core is about repeating relationship patterns and helping people acknowledge those. And then ACT is acceptance and commitment therapy, which is an absolutely wonderful model that I'm trained less in, but know the core basics of, but are hugely popular in pain management. And my colleagues are skilled in delivering ACT interventions that absolutely look at a very similar concept of when we just need to be with and notice, and that there's things that we do without realizing that take us further away from our goals and our values. And you're then, what ACT is wonderful at is this fluidity of, we're always on a journey. You never achieve a goal, because even if you get to a certain level, you're actually then, one day you'll be closer to that goal, one day you'll be further away from it. And then the goal will transform into the next level of thing. So it's taking away the pressure often of, I need to do this at a particular point in time. And it's much more value-driven behavior. What matters to you? And can you do that just bit by bit every day? Can you notice and recognize what's taking you away? And can you allow yourself to go towards? So mindfulness is key, and noticing and being aware of self, and being able to think about the experiences, particularly from this that we rely too much on the language, that we rely too much on the voice that we hear in our heads telling us to do things. And so ACT has got this wonderful phrase of, I notice that I'm telling myself this. So you're starting to separate out what is an actual idea versus what is you as a core person. So I'm noticing I'm having the thought that I don't want to do this. It's not that I don't want to do it, that's the thought that's dominating. And this great idea as well that it's the brain that tells us that the brain is the most important organ of the body.
A bit self-serving of the brain then.
Yes, and actually sometimes we need to just turn off all that chatter and just sit with, because the inner wisdom of the body can then come to the fore. And so the combination of ACT and value-driven mindfulness, and then CAT getting into the relational aspect of the repeating patterns, those combinations together are really wonderful for setting the frame for pain management, I think. And you'll find a lot of pain psychologists will be talking about these kind of ideas alongside the more traditional CPT approaches.
Well, can you just say what ACT is? Because I think that's the one thing we haven't got. Just
Yes.
what the acronym stands for.
ACT stands for acceptance and commitment therapy. And it's Stephen Hayes and Russ Harris are two very prominent ACT psychologists. And it was Russ Harris that actually produced a wonderful guide to managing in the COVID based on ACT principles called Face COVID. I've been circulating around a lot of different services. I think I sent it to some of your colleagues, but I can send it to you as well. About the mindfulness and what's in our control and engaging with value-based activities right now. You know, it matters to me to support my community. So what can I be doing daily that's supporting my community? It matters to be in touch with people and just allowing the anxieties to come and be experienced, and acknowledgement, validating changes the experience of the emotion, changes. If you attend to your pain, it changes the experience of it. So all of this coming toward, rather than trying to fix and cure and move beyond too quickly, trusting the body's wisdom and the mind's know-how to work out themselves if you create the right conditions, hugely empowering for clients, but hard to do as practitioners because we like rescuing.
I also like fixing.
And fixing, yes.
Thank you so much, Mel, for your time and your wisdom today. That's been a fascinating look at some of the things that you're dealing with, and the exciting things, the barriers, and the current situation, and some good advice there for us all, I think.
Yeah, well, thank you very much for the invitation to talk, Vicky. It's been good to reflect on this.